Okay, in our video series of cardiology lectures, in this video we are going to talk about hypertrophic cardiomyopathy. We are going to talk about its clinical presentation, its diagnosis, causes and treatment of hypertrophic cardiomyopathy in detail. We have a case here, a 23-year-old young basketball player, a national player, is playing on a national level. His match is being aired on national TV and the whole nation's hopes are pinned to him. He is playing well, he is doing well, but all of a sudden he collapses, he falls down, and he becomes unconscious. The medical team reaches him. They start CPR, but despite all the resuscitation effort, he doesn't make it. He dies at that point. He develops a cardiac arrest. Later on, he was diagnosed that he was having a hypertrophic cardiomyopathy. Another player, Antonio Puerta. Antonio was playing La Liga while he developed a cardiac arrest due to hypertrophic cardiomyopathy. While these patients are totally asymptomatic before that and they are athletes and they are doing very well, all of a sudden they develop cardiac arrest and they die. This is a presentation of hypertrophic cardiomyopathy. What is hypertrophic cardiomyopathy? How does it present and how does it affect the heart? Today we are going to talk about that. Hypertrophic cardiomyopathy is a common cause of death in young population. What is hypertrophic cardiomyopathy? Now we are going to talk about that. This is a picture showing a normal heart, the right atrium, right ventricle, left atrium, left ventricle. In this picture, you can see hypertrophic cardiomyopathy has taken place. Hypertrophic cardiomyopathy is thickening of the left ventricle, thickening of the heart tissue. Look at the left ventricle's walls. They are very huge and thick. And this thickening of the left ventricular walls takes place asymmetrically. By asymmetrically, it means that the septal wall thickening is much more as compared to the rest of the left ventricular wall. Overall, the left ventricle is getting bigger and the walls are more thicker now, but the septum is more thicker than the rest of the wall. Therefore, asymmetrical thickening of the left ventricle takes place. Now, when the walls are thick, there are increased chances of arrhythmias to develop. There is increased chances of ischemia because the blood flow cannot penetrate through these thick walls of the left ventricle. Therefore, arrhythmias generate and those arrhythmias result in cardiac arrest. Therefore, the sudden collapse of the young athlete. Hypertrophic cardiomyopathy is a genetic cardiac disorder characterized by unexplained left ventricular hypertrophy. The left ventricle is getting thick, the left ventricular walls are getting bigger and typically involving the interventricular septum. The septum is getting more thicker as compared to the rest of the walls. And remember, in the absence of other causes such as hypertension, aortic stenosis, the patient does not have any hypertension, aortic stenosis, but still the patient's cardiac walls, the patient's left ventricular walls are getting thick and bigger. That is hypertrophic cardiomyopathy. It is unexplained. It is idiopathic. The hypertension, aortic stenosis also cause left ventricular hypertrophy, but that is secondary. Hypertrophic cardiomyopathy is the one where it is unexplained, where we do not know what is causing this thickening of the left ventricular wall, but still it is taking place. The patients are all young, the patients are all healthy. That is hypertrophic cardiomyopathy. Remember not to confuse the left ventricular hypertrophy due to hypertension and aortic stenosis and other causes with hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, it's idiopathic. We do not know the cause. It's genetic most likely. And the patients are all healthy, all young, all athletes. In secondary causes like hypertension, aortic stenosis, they cause left ventricular hypertrophy, but they are not hypertrophic cardiomyopathy. So that is a very important point. Now, hypertrophic cardiomyopathy can be either obstructive or non-obstructive. What does obstructive hypertrophic cardiomyopathy means? That is also called as HOCM, hypertrophic obstructive cardiomyopathy. Basically, asymmetrical thickening of the left ventricle takes place where the septum gets more thicker as compared to the rest of the wall. Now, when the septums get more thicker, it obstructs the flow of blood from the left ventricle into the aorta. That is called as hypertrophic obstructive cardiomyopathy. Basically, this left ventricular septum and this mitral valve leaflets, they collapse with each other during the systole, and when these two collapse with each other, they obstruct the blood flow from the left ventricle into the aorta. That is called as obstructive hypertrophic cardiomyopathy. In non-obstructive hypertrophic cardiomyopathy, the left ventricular walls are thick, but the blood flow from the left ventricle into the aorta is not blocked, is not obstructed. Therefore, that is called as non-obstructive hypertrophic cardiomyopathy. Remember, hypertrophic obstructive cardiomyopathy is much more common than non-obstructive cardiomyopathy. Now coming to the causes of hypertrophic cardiomyopathy, remember hypertrophic cardiomyopathy is mostly idiopathic. We do not know the cause. We do not have any secondary causes like hypertension or aortic stenosis. The patient is all healthy. The patient is all fine. And that patient has left ventricular wall thickening. Therefore, genetics play an important role. The patients usually have a family history of hypertrophic obstructive cardiomyopathy. These patients will have other family members who developed sudden cardiac death in their family. And these patients would tell you that, doctor, in our family we have this problem that all of a sudden young people die with cardiac arrest. We do not know the cause, what is causing this. These are the families that must be screens for hypertrophic cardiomyopathy. It is genetics that play a role. It has an autosomal dominant pattern, and mutation of myosin heavy chain in the sarcomere in the heart tissue is mutated. Therefore, thickening of the left ventricle takes place. Now, this is a picture showing a normal histology picture of the cardiac tissue where there is a linear distribution of the myofibrils in the heart. But what happens in hypertrophic obstructive cardiomyopathy is that due to myosin chain mutation, this myofibril distribution is very haphazard, and there is a disarray, and there is fibrosis of the heart tissue. So the heart wall thickens, and it thickens asymmetrically, and when it thickens asymmetrically, the blood supply cannot be provided to it properly. Therefore, ischemia takes place. Therefore, arrhythmias takes place, and those arrhythmias kill the patient. Now, in hypertrophic cardiomyopathy, when the walls are getting more thick and they are getting thick more asymmetrically, the left ventricular chamber size is also decreasing due to the thickening of the wall. When the left ventricular chamber size decreases, the blood filling cannot take place properly. When the blood cannot fill in the left ventricular wall properly, diastolic dysfunction takes place, resulting in diastolic heart failure. I have a complete video on diastolic heart failure. You can check out that video in my cardiology lecture series. And outflow obstruction also takes place. As I said, the septal thickening is taking place, and that septum during the systole collapses with the mitral wall. When it collapses with the mitral wall, it blocks the passage of blood from the left ventricle into the aorta. That is called as left ventricular outflow obstruction, resulting in hypertrophic obstructive cardiomyopathy. Outflow obstruction takes place due to systolic anterior motion of the mitral valve during the systole. This is a very high yield point, very commonly tested point in exams. Now, in which conditions left ventricular outflow obstruction increases or is worsened? It is worsened in exercise and in stress, because in exercise and in stress, the heart is pumping very rapidly and the heart does not have enough time to fill with blood. When the left ventricular doesn't get enough time to fill with blood, it has less blood each time it is pumping out the blood. When there is less blood in the left ventricle, the chances of interventricular septum to collapse with the mitral valve increases. Therefore, left ventricular outflow obstruction is worsened in exercise, in stress, where there is tachycardia, because less filling of the left ventricular valve takes place. Whenever there is dehydration, whenever the patient is using diuretics, ACE or ARBs, the patient is losing water and there is less volume of blood in the body because the volume contraction takes place due to the loss of fluid. In such cases, the left ventricle cannot open up properly. The left ventricle is having less filling of the blood. Therefore, the chances of a collapsing of mitral valve with the interventricular septum are increased. Therefore, left ventricular outflow tract obstruction chances are also increased. Now, coming to the clinical presentation. In the clinical presentation, if it is a non-obstructive type, which is not obstructing the blood flow from the heart to the body, the patient will be totally asymptomatic. But if it is an obstructive type, then it will be a common presentation that the patient will have first presentation during the episode of exercise, where the patient is doing some extensive athletic work or is exercising, playing football, playing basketball, and all of a sudden patient collapses, patient gets syncope. Why does that happen? Because the body cannot receive enough blood, the brain cannot receive enough blood, therefore the patient falls down. Patient can experience syncope, dyspnea on exertion, they get short of breath, or in some cases when the heart is not receiving enough blood during exercise, angina, chest pain takes place. And most commonly, patients are totally asymptomatic, patients are healthy, patients are young, and all of a sudden they get syncope. Sudden cardiac death can also be an unfortunate presentation during or after an intense physical exercise, where the heart tissue is wanting more blood, but the heart tissue is very thick and cannot be perfused thoroughly. Therefore, cardiac arrhythmias take place, and those cardiac arrhythmias kill the patient, resulting in sudden cardiac deaths. Therefore, a common presentation in athletes. On physical exam, you would see a systolic ejection murmur because there is obstruction to the blood flow. Whenever there is systole, the blood cannot flow out. Therefore, you would see the difficulty in blood flowing out in a form of murmur, a crescendo decrescendo murmur, because the pathway of the blood flow is obstructed. Remember, this murmur is just like aortic stenosis. Many times you would receive scenarios and that patient will be having a typical presentation of a hypertrophic cardiomyopathy, but the murmur will be just like aortic stenosis, and it will become very confusing for you that whether this is the hypertrophic obstructive cardiomyopathy or aortic stenosis. But remember, a patient who is young is having more chances of hypertrophic obstructive cardiomyopathy, and the patient who is old is having more chances of aortic stenosis. With that, there are other maneuvers that can help you differentiate between aortic stenosis and hypertrophic obstructive cardiomyopathy. So a patient will have crescendo and decrescendo murmur, just like this. Now, another important point is that there will be pulses, bispherems, bifid pulse. What you would see is that when you will palpate their pulse, you would feel that the patient is having bifid pulse, because initially when the systole is starting to take place, initially a gush of blood would go out of the heart, and then all of a sudden obstruction would take place. A gush of the blood would flow out of the heart, and then obstruction would take place, and then the blood will flow more slowly. Therefore, what you would see is that there will be bifid pulse, also called as pulses bisferens. Another important point is that since the left ventricular walls are thick, an extra heart sound that you would hear in these patients will be S4, because S4 occurs in hypertrophy of the heart. Now, many students find it very confusing that they would ask in exams that patient is doing a certain maneuver like Valsalva maneuver, hand grip maneuver, standing, leg raise, and what is its effect on the heart murmurs, whether the intensity of the murmur increases or decreases with these maneuvers. I have a very simple way to remember all these maneuvers and their effect on the intensity of murmur. Remember a simple single line that all murmurs increase with the increase in preload except hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Now remember, all those murmurs that would cause increase in preload would increase all the murmurs except two murmurs, hypertrophic obstructive cardiomyopathy and mitral valve prolapse. That is also a way to remember how to differentiate between hypertrophic obstructive cardiomyopathy and aortic stenosis. In patients who are having aortic stenosis, if a murmur increases the preload, the murmur intensity would increase. But in hypertrophic obstructive cardiomyopathy, if the maneuver increases preload, the intensity of murmur would decrease. So there is also a way to differentiate hypertrophic obstructive cardiomyopathy from aortic stenosis. Now, coming to the maneuvers, you can simply remember that hypertrophic obstructive cardiomyopathy would decrease with passive leg raise, because passive leg raise increases return of the blood flow to the heart and increases preload. So all the murmurs would increase with passive leg raising except two murmurs, hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Now, what will be the effect of squatting and hand grip on the murmur of hypertrophic obstructive cardiomyopathy? Now remember, when the blood is jetting out from the left ventricle into the aorta, it would produce more sound when the aorta is empty. When the aorta has less blood, it would produce more noise because empty vessels makes more noise. When there is more blood in the aorta, the jet that is coming out from this obstructed pathway would produce less sound. Therefore, squatting and hand grip increases the afterload, and increase in afterload would cause more blood to be present in the aorta. Whenever there is more blood present in the aorta, the noise that you hear through your stethoscope would be lesser. If the afterload is less, there will be more noise that is produced over here. So squatting and hand grip increase afterload, increase blood in the aorta, and therefore the murmur intensity is less in squatting and hand grip in case of hypertrophic obstructive cardiomyopathy. These things make sense when you understand the physiology. Like cramming these maneuvers would be very difficult for you, but you have to make some sense out of these things, that what is the mechanism that is going on that is resulting in increase and decrease of the intensities. What will be the effect of Valsalva and standing on the murmurs of hypertrophic obstructive cardiomyopathy? Valsalva and standing decreases the preload. Whenever there is decreased preload, all murmurs would decrease except hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Therefore, there will be increase in the murmur of hypertrophic obstructive cardiomyopathy in Valsalva and standing. Now coming to the diagnosis of hypertrophic cardiomyopathy. The main investigation, the initial and the best investigation is echocardiography. You perform echo and you look at the heart. What you see is that there will be an asymmetrically thick left ventricular wall greater than 15 or equal to 15 millimeter in adults, and there will be predominant septal thickening, asymmetrical thickening of the left ventricle. This is a cross section showing extremely thick left ventricular wall. This is a picture showing upside down heart. These are the atria and these are the ventricle. This is the right side, this is the left side. And look at this. This is extremely thick wall of the left ventricle on echo. Now, if you are good at ECG, you can also get an idea about hypertrophy occurring in the heart on ECG. I have explained Scolio-Lyon criteria that tells us about left ventricular hypertrophy in detail in my video on left ventricular hypertrophy. You can check out the link given in the description below of that video. You would see deep Q waves in inferior and lateral leads. Inferior 2-3 AVF and lateral leads, you would see deep Q waves and giant inverted T waves in the precordial leads. Now this is a picture showing 2-3 AVF, and in 2-3 AVF you can see deep Q waves. Look at the QRS. This is the QRS and these are the deep Q waves. These are the deep Q waves in AVF. Inverted T waves in V1, in V2. These are the precordial leads. So these are the findings that you see on ECG with hypertrophy. And also look at the massive QRS complexes and how you apply Scolio-Lyon criteria. I have explained that in detail in my left ventricular hypertrophy video. Whenever a patient is diagnosed with hypertrophic cardiomyopathy, it's important that you screen the family members, you screen them for hypertrophy of the heart, because that would prevent early death in these patients. Genetic testing can also be done. After the incidents of sudden death of basketball players and these players in football, FIFA and Olympics have made it mandatory that every athlete needs to be screened for hypertrophic cardiomyopathy before they go for participation in any sports. This shows the importance of detection of hypertrophic cardiomyopathy. Now coming to the treatment of hypertrophic cardiomyopathy. In the treatment of hypertrophic cardiomyopathy, it is very important that you prevent all the exacerbating factors. As we said, dehydration is an important cause that would exacerbate the outflow and would result in the symptoms. Avoid strenuous exercises, avoid hot weather, because hot weather would cause dehydration and it would further cause decrease in preload and increase the chances of left ventricular outflow obstruction. Limit alcohol intake because it also causes dehydration as well as also directly affects the heart tissue. Now, if the patient is asymptomatic, that patient does not need any intervention. If there is no obstruction, you just keep monitoring the patient with serial echocardiography and you monitor that whether patient does not develop any obstruction in the future. So only monitoring and no intervention is done in asymptomatic patients. In the patients that are symptomatic, you have to decide whether you are going to proceed ahead with pharmacological therapy or you have to proceed with surgical treatments, because treating these patients is very important to prevent sudden cardiac death. In the pharmacological therapy, we give beta blockers, rate controlling medications. Why are we giving rate controlling medications in patients with hypertrophic cardiomyopathy? We are slowing down the heart so that the heart fills up with blood every time properly in the diastole. When the heart fills up properly during the diastole, there is more blood present in the diastole. More blood present in the heart, there are lesser chances of the outflow obstruction to take place. When there is less blood present in the heart, there are increased chances of mitral valve and septum of the heart to collapse and resulting in outflow obstruction. So we want the heart to be filled up with blood properly. We want the patient to be hydrated all the time. We want the patient to not to do strenuous exercises so that the chances of left ventricular outflow obstruction are decreased. Therefore, beta blockers are given. Propranolol 40 to 80 mg per orally PD. Atenolol can also be given 25 to 150 mg per orally OD, or nedolol 40 to 80 mg per orally OD. If the patient is unable to tolerate beta blockers, like in cases of asthma or COPD where the patient has contraindication to it, you can use verapamil 40 mg per orally TDS, a calcium channel blocker, diltiazem 60 mg per orally TDS. So, if the pharmacological therapy fails or if the patient is severely symptomatic and initially you decide that you are going ahead with the invasive therapy, what you do is that you treat the outflow obstruction. What you do in outflow obstruction treatment is that you remove the extra part of the septum so that the septum does not cause obstruction to the left ventricular outflow tract. In the septal surgery, what you do is you do septal reduction, you do myomectomy, a surgical procedure where you remove the part of the septum, or you do alcohol ablation where you inject the septum with a substance like alcohol that causes necrosis of that part of septum which is causing obstruction to the outflow. This is a picture showing the thick septum, and look over here, myomectomy is done, surgical procedure to remove that extra part of the septum so that so that it does not cause any obstruction. So the medications that you need to avoid in patients with hypertrophic cardiomyopathy, remember these are relative contraindications. If indicated, you can give these patients with low dose of diuretics, but overall high dose diuretics are avoided in these patients because they would cause dehydration and increase the left ventricular outflow obstruction. Digoxin, because it increases the contractility, and when there is increased contraction of the heart, the chances of obstruction increases. ACE inhibitor ARBs, spironolactone, they also cause diuresis. Nitrates is a venodilator which decreases the preload. Whenever there is less blood in the heart, the chances of obstruction are more. Ionotropes also cause increased contraction. Therefore, these medications are to be avoided in patients with hypertrophic cardiomyopathy. In simple words, ionotropes, after load reducing drugs, preload reducing drugs increase the chances of obstruction, and these are contraindicated in obstructive cardiomyopathy. Remember, in my video on diastolic heart failure, we discussed the only options that we have in any patients with diastolic heart failure is that we give rate controlling drugs like beta blockers and calcium channel blockers. Almost all other drugs are to be avoided in these patients. So a simple way to remember, anything with diastolic heart failure, you give rate controlling drugs. Now, it is very important to remember that whenever you have a patient with hypertrophic cardiomyopathy, almost all patients are to be screened and checked, and they need to be put on automated implantable cardioverter defibrillator if there is a risk that that patient can develop arrhythmia. Because this is basically a machine that is put in the heart, a probe is passed through the heart and machine is attached to the patient's body, and whenever there is any abnormal rhythm in the heart, any abnormal electrical activity going on in the heart, this machine detects it and bombards it with a current and stops that abnormal activity. Therefore, arrhythmias cannot develop. When the arrhythmias cannot develop, the patient cannot develop cardiac arrest. Therefore, it is very important to consider automated implantable cardioverter defibrillator whenever there is a chance that a patient can develop arrhythmia due to hypertrophic cardiomyopathy, and it prevents sudden cardiac death. So this was all about hypertrophic cardiomyopathy. If you liked my video, please click on the subscribe button and make sure to check out my other lectures on ECG, video series, cardiology lectures, neurology lectures. I have a whole playlist on all other subjects, and make sure to support this channel on Buy Me a Coffee. We talked about what is hypertrophic obstructive cardiomyopathy, the septal thickening take place, it's a genetic disorder, the obstructive and non-obstructive type. Genetics play an important role. Myosin heavy chain, myofibril disarray takes place. Outflow obstruction due to anterior motion of the mitral wall. What worsens the left outflow obstruction, the clinical presentation, the crescendo decrescendo murmur, maneuvers and its effect on the murmur intensity, echocardiography, the best test, the ECG findings. We talked about the treatment. In the treatment, you give rate controlling drugs like beta blockers and calcium channel blockers. The surgical treatments include septal reduction, the medications that are to be avoided in these patients. Automated implantable cardioverter defibrillator, very important point. So if you liked my video, please click on the subscribe button and make sure to check out my other videos. Thank you very much.